like to take a minute to just welcome our keynote speaker today, a professor of the University of Saskatchewan, an academic forensic psychiatrist, and the founder of the forensic subspecialty in Canada, Dr. Mansfield Mela. At this time, I want to invite Dr. Mela to talk more about a decision tree algorithm that guides prescribers on psychotropic medication management for FASD. So I'm going to pass it over to him.
Thank you, Chelsea. Can you confirm you can hear me, Chelsea?
Yep, I can hear you. I can't see you, but I can hear you.
Yeah, I think that's where our first issues are going to start. I'm trying to find the button to share my screen.
Right.
But I'm sure someone is going to come to my rescue right now because the easy button of sharing the screen disappeared.
Oh.
And I have more actions, but it doesn't allow me
next
to
to
share.
Your camera, mic, and then the share button right next to the leave button. It's
Yes,
like a little box
good.
with the arrow
Absolutely.
pointing up.
Yes, thank you.
No problem.
And then it asks me
To share your window with the PowerPoint. Yep.
Yeah. And then I have the psychotropic medications. I believe it is sharing. Is that correct?
Yes, we have the slides. You just have to move into presentation view.
Very good. And I believe it's there.
Beautiful. Yeah. Thank you.
Okay. So thanks for bearing with me. We just tested this a couple of minutes ago. So whatever is happening was trying to put a damper, but it won't. So as Chelsea said, I also just want to take a minute to welcome everyone for linking into this webinar. I know the two topics seem similar, but they're actually very different and totally different methods of research. So you see as I move forward on the presentation. So the first aspect is to talk about the role of psychotropic medication algorithm, or otherwise a decision-making tree in the treatment of fetal alcohol spectrum disorder. Thank you so much, Sorry Place, for putting this webinar together. As you all can imagine, it would have been excellent to be in person, but also we have avenues of responding to questions. And I believe my research coordinator, Monique, is on the line. And if there are any questions that we need to funnel to the team, we can do that. I also just want to use the opportunity to thank a number of people that I'll be pointing out as I do the presentation. I'm really just the voice. There are multiple individuals that contributed to this monumental task that took us about 4 years to complete, and now we are in the implementation phase. So what you're going to see, obviously, as according to our guidelines, I have to indicate to you that during the process of developing this algorithm and the implementation, we've had a number of funding agencies support the work. I'm based at the University of Saskatchewan, so we were fortunate to be funded to host the first meeting of the experts panel in Saskatoon in 2016, and those funds came from the Saskatchewan Health Research Foundation. I'm also a lead researcher under the Canada FASD Research Network, known as CAN-FASD, and my research is supported through CAN-FASD. In the process of getting the algorithm, the research that was done, the publications, I don't believe that I've had a specific conflict, and I need to declare that to you. As I mentioned, I will show you in a few minutes some of our co-investigators a number of physicians and participants that were part of the team over the 4-year period. Indeed, in 2000, just as the pandemic started, we finally got the article on the algorithm published, and that reference is a significant one for anybody wanting to study more about what we did, as well as to understand some of the research behind the algorithm. So what am I hoping to cover in the next 45 minutes or so? It's important to know that the work that we did is centered around prescribers, so that prescribers of medications, specifically psychotropic medications, these are medications that have an impact on the brain function, will be familiar with the science behind prescribing, science behind the response of those with FASD when those medications are given to them. So we were very fortunate to scan the published literature and find out the current state of use of those medications in those with FASD, and I'll share some of those findings with you. To develop a decision-making tree, this is a process by which a clinician or a prescriber will undertake to go through the symptoms that make the disability, that require treatment, choose from a range of medications, justify the choice, and ensure that there is a unity of purpose in going forward with the treatment. As I indicated, that this was targeted towards clinician prescribers, you will see in the presentation that there is a significant role for caregivers and frontline staff, who for the most part actually know the individuals with FASD better than the clinician. And so you see me referring to the role of the caregivers and frontline staff in that context. I hope also that by the end of the presentation, if there are specific clinicians in the audience or even the families, you see that we provided a step-by-step approach on how this can actually be practically carried out. For the audience, I'm hoping that these terms are not new. I put them forward because, as you may or may not know, Canada back in 2016, through a very extensive consultative process, made the decision to adopt the title Fetal Alcohol Spectrum Disorder into a categorical disorder, meaning that many individuals that have the deficits and challenges associated with the consequences of prenatal alcohol exposure will fall within that group of terminologies. But of course, we realize 2016 is distantly placed from when we began to know about the adverse outcomes related to prenatal alcohol exposure. At the beginning, back in 69, 73, the terminology at the time was fetal alcohol syndrome. And over time, due to the focus being on the physical abnormalities of the prenatal alcohol exposure, we were missing quite a number of individuals that did not fit that criteria, and therefore terms after that have evolved. So I give you this list I don't have to go through them, but this will cover most, if not all, of those that we currently diagnose with fetal alcohol spectrum disorder. The process of diagnosis, at least in Canada, is guided by the consensus diagnostic guideline that was part of and the result of the extensive consultation I mentioned and has been published in 2016 in the Canadian Medical Association Journal. I believe most clinics in Canada adhere for the most part to this process, and families are becoming aware of these terms being in sync with fetal alcohol spectrum disorder. I'll tell you a little bit about how our project of the algorithm began, and this I will credit to the Family Advisory Committee. I almost can bet that within the audience today, there will be some members that associate with the Family Advisory Committee. It is actually a committee that is paired with the Canada FASD Research Network that I just mentioned a few minutes that I'm a research lead with. This is a group of caregivers who have come together, and kudos to them, have really moved the dial on FASD research, funding, implementation, and services over the years that they've come together, because they know firsthand the challenges, the needs, and potentially the solutions of all the challenges that people with FASD go through. So back in 2015, members of the Fetal Family Advisory Committee approached our research team with multiple questions around medication. Some of it, I hope you will be familiar with, because some of these questions are usually the same, and some of it did not have answers. For example, where do we get information about medication that is being prescribed for people with FASD? What are the common side effects of these medications? Are these things that we're seeing in our loved ones side effects of medications? How many medications do you need for an individual with FASD? What kind of knowledge should people who are prescribing for individuals with FASD have around the medicine, the physiology, the basics of the brain when they are prescribing for that? And what is the current evidence by which those medications were being prescribed? In short, what they came to us was that we are concerned about our loved ones who seem to get too many medications, causing them to not function and leading to too many side effects. Can you help us? And those were the questions that were posed to us at the time. In summary, we left with the recognition that there was a lot of challenges in understanding the role of medications, specifically psychotropic medications. Now, I want to digress a little bit for the audience to recognize that I'm focusing a lot today on psychotropic medications, meaning I'm drawing your attention to the brain function of FASD. But I do not want us to forget that the consequences of prenatal alcohol exposure is one that affects virtually all the organs of the body, from the heart to the kidneys, from the kidneys to the skin to the muscles, and all of those things sometimes require certain medications. That's not what I'm talking about, but it's important to not neglect those other problems that individuals do have. So basically, as a team, we began to look at these questions that were posed to us, and I would describe the team. I think it was very strategically crafted to bring the right people to address a lot of the issues. In our knowledge, we knew that no two individuals with FASD were alike. And in fact, the neurocognitive consequences of prenatal alcohol exposure are so varied that it's been a big challenge for us to profile individuals with FASD. There's research looking into that mode of recognition, but we were not there yet in 2016. We were also very well aware that at the time, there was a challenge in terms of how to actually diagnose individuals with FASD. The challenge at the time was that there's a lot of diagnoses that replaced or were given in place of FASD. Those diagnoses did have methods of treatment that involve psychotropic medications. As well, those with FASD and those additional diagnoses did not just have a few, they had multiple diagnoses given. As such, we were left with how do we sieve through the different diagnoses that require treatment? Our team also looked at the literature and the progression of research in the use of psychotropic medications over time. And we came to realize that there has really been a slow pace of development when it comes to the use of medications for people with FASD. We wondered if this had to do with some of the stigma that the disorder suffered from, but also that related to some of the problems that hindered the research over time. For example, as of 2016, we had gone to a site that records all high-powered research that we call randomized controlled trials. And as of that time, there were about 3 research projects that had to do with advancing the role of medications in FASD. And none of those were less than 10 years in the making. And none of those had produced any results as of the time. So we were left with really a dearth in the available literature on what we could do to provide information that was relevant to the topic of the use of psychotropic medications. So I provide this information to you first and foremost as letting you recognize the terrain that we joined to participate in this research, the concerns that had come up, and some of the difficulties in the existing literature. Chelsea, I'm getting a note that my video is not working. I'm just wondering if that is correct and if you can confirm. Note that I'm not able to see the screen apart from my presentation.
I had a feeling I didn't want to interrupt you because you seem like you're in a flow. But your screen share is perfect. It's just your camera. We're not seeing your face. So if you pull up the Teams meeting, there might be a little box in the corner. Your camera would be X'd out and you just want to press your camera button.
Oh my. Can you tell me if it has done anything? I'm sorry to break the presentation.
It's okay. It did look like
I may have to stop sharing and return to this slide. I'll ask for your patience, the audience. My camera is on, but I don't know what could be happening.
It's still black. Do you want to try turning it on and off once more?
Okay, just done that again. So I am sorry, I don't know what the problem is.
Yeah, it's turned on my end, but I do see the black screen just like Chelsea does.
Yeah,
Do you
I
what
am
do you
on
see?
presenter mode.
What
You
do
know
you see
what?
on your end, Dr. Mela? Do you see yourself on screen or no?
No, I don't. Interesting. I saw myself when we tested, but not
Yeah, I
anymore.
did
So,
too.
okay. You know what? I'm so sorry about this. I just realized that I've been speaking without you seeing me. So bear with me. It's one of the challenges of living in this era of post-COVID era.
Dr. Mila, that's a good point. Do you have a cover over your camera? Is there something, like, are you on a laptop? Is the cover on?
I am. That has happened to me before. I have moved it, but no, I'm not. The cover is not protecting it. Yeah, that has happened before. So sorry about that. We may have to continue with what we have. Can you see the screen now?
Yep, we can see the
Okay.
screen. Yeah,
All right.
continue on and we'll figure it out for the next
Sure.
presentation. No worries at all,
Absolutely.
okay?
Okay, great. Thanks for bearing with us. Okay, so a summary of some of the things that we found in the literature that would be relevant to developing a decision tree were that one, because FASD, for most of you who may know, every medication that is prescribed for any person has to have approval from the approving or regulatory body. So in Canada, we have Health Canada that approves all medicines. Unfortunately, FASD was not a diagnosis enough to have any medication approved by Health Canada. In the United States, it's Food and Drug Administration. So we are starting from a point of disadvantage in that if you're prescribing medicines for people with FASD where there is no approval for, you have to use what we call off-label guidelines. What that means is that you have to justify why you're prescribing it and you have to follow certain steps to be able to get that actually completed. So that's the first starting obstacle. The second issue had to do with research that one of our colleagues actually on the panel, Osman Ipsiroglu, that discovered. He had taken about uh, a dozen individuals or multiple dozen individuals with FASD, but who also have an added diagnosis of a sleep disorder. And over a period of time, his team was able to discontinue about 137 different medications for these individuals, suggesting that probably there were just too many medications being prescribed for the individuals with FASD who did not have a clear need for those. The other worrying concern for us was that because as of the time that we were doing this study in 2016, others had begun to suggest that if you do not have an effective treatment, if there is no medication being prescribed for those with FASD, why then diagnose it? And so this was quite a complex problem because, as you can see from the third bullet under, these researchers were suggesting that there was actually a hesitation to diagnose people with FSD. So that means we're not even identifying them. How much more do we actually go ahead to prescribe for them? So that is the challenge. Now, what I would like to do next is to give a hypothetical situation which in my practice, even though I mainly deal with adults, but I consult a lot with people who treat younger patients, and as well, a lot of my adult patients were younger patients before they came to me. So this is not a completely out of the box example, and I'm almost certain that for those in the audience, this example may actually ring true for some of the cases you're dealing with. So Tony, I use this scenario vignette as a 17-year-old who was a product of a violent rape. Tony's mother smoked cigarettes normally during pregnancy, but because of this impact of the assault, relapsed into cannabis use and was drinking alcohol during that. Now, I'll stop for a minute to make my point, which I like to do in most of my presentations, that for the most part, previously, the work around FASD had assumed quite unusual public health approaches of blaming women. This vignette hopefully cast an awareness to most people to know that there is never been a situation whereby a woman who is pregnant will specifically and deliberately choose to use alcohol for the singular purpose of causing harm on the fetus. That is not something we know. So there are multiple reasons, and part of the prevention method or approach is to uncover some of the reasons so as we can target them specifically. Following birth, Tony's mother couldn't look after Tony, and Tony was adopted. Consequently, Tony's growth in childhood was characterized with significant temper tantrums, early aggressive behavior, and in this instance, Tony had assaulted his teacher and was suspended from school. During the process, the adopted parents sought to uncover what problems Tony had. And part of that investigation led to him being diagnosed with fetal alcohol spectrum disorder according to the Canadian guidelines, but not before having been given a range of other diagnoses: oppositional defiant disorder, attention deficit hyperactivity disorder, reactive attachment disorder, borderline personality disorder, panic disorder, and explosive disorder syndrome. He was noted to be quite irritable. He slept poorly. And even with his siblings, he was unpredictably aggressive. This made for quite a difficult parenting, and every attempt to try and guide his behavior sometimes led to feeling easily frustrated to the extent of banging his head. Tony was known to be intolerant of change, and he was not good at waiting for his needs to be satisfied. However, Tony was also noted to be generous. He was liked by his friends, and he was great in snowboarding. Now, before I kind of bring the algorithm into focus, I needed to understand that Tony, at the time of this consultation, was on the following medications. And I hope that many in the audience will know some of this, but I'll just quickly run through them. So Olanzapine, as you can see, is a medication that is used mainly to tamper down the appearance of being out of reach with, out of contact with reality, as well as for use for mood problems. But Tony was being given for the purposes of dampening the aggression. And the word PRN means it is given when needed. He was also on a stimulant medication, popularly known as Vyvanse, lisdexamfetamine, and his dose had been increasing from 10 to 20 to 30 milligrams. He was on a medication known as Aripiprazole, which is usually called Abilify. He was also on a sleeping medication, melatonin. Many of you will be aware of that. He was prescribed an antidepressant, anti-anxiety, and a sleeping medication known as mirtazapine, popularly known as Remeron, and his dose was reasonably high at 45 milligrams, and he was also taking an anti-anxiety medication known as clonazepam 1 milligram daily. So at the age of 17, he was on 5+ medications. And at the time, as you can see, there was little progress in dealing with those irritable behaviors, aggressive behaviors, poor sleep problems, temper tantrums, head banging, and the difficulties that led to this consultation of assaulting his staff. Not to complicate the picture, obviously one of the things that we sought to do in this development of the algorithm is to begin to think differently. So what did we do? I'm sorry that this slide doesn't do justice to the individuals that I desire to introduce, but it will help, I think, the audience to be aware that we have, among those that came together in 2016 to begin the process of first evaluating the science, looking at the questions that the Family Advisory Committee was asking and how to formulate this decision tree, are a number of clinicians. We had pediatricians, we had pediatric neonatologists, we had pharmacologists, we have psychiatrists, and what I think was very unique to this body is that we had two individuals. We had an algorithmic expert, Dr. David Oza, who, to his confession, knew nothing about FASD, and his role was to help us maintain the rigor of the science in the things that we did. But I think for me, the most relevant person that I'm so pleased for their contribution is Dorothy Reed. Dorothy Reed was then the co-chair of the Family Advisory Committee. And as you recall, I mentioned that the Family Advisory Committee was made up of caregivers that knew more about FASD than ourselves. So what we did was bring this panel together. We first met in 2016. We looked at what had been published in the literature, which we then published what we call a systematic review. So looking at all the articles that had been written on fetal alcohol spectrum disorder and the use of psychotropic medications. We subsequently met as a group on 4 different times to try and reach a consensus. I cannot give you the details of the discussions, but the family physicians on the board had a different idea, the pediatricians have a different idea, the psychiatrists have a different idea, but I'm pleased to say that we did come up with the algorithm, which essentially looks like this. And I'm going to describe it in more detail, but this is the summary of it that, and is available, by the way, on the CAN FASD website. And some of our encouragement to families is that be familiar with it, support your prescriber with that knowledge, and monitor your loved one based on that knowledge to ensure that this first iteration is our first iteration, because as I mentioned earlier, we do not have high-level science that has looked at the role of medication specifically in the way that all other disorders do. So we need to set up a mechanism for revision and complete reorientation of this. In summary, what you see from your left to the right is that the individual first will have to have a diagnosis of FASD. The manifestations of the major concerns at the time of the consultation require some neurophysiological basis. And this we found in the 4 clusters that you have. So going from left to right, you have the hyperarousal cluster, the emotional regulation cluster, the hyperactive neurocognitive cluster, and the cognitive inflexibility cluster. On top of those clusters, a summary of some guide for the prescriber, for the family to be able to isolate what are the key behavioral patterns, manifestations of the individual that would make it likely to fall into one or more of those clusters. Once the clusters have been clarified, the next step in the use of this decision tree is to ensure that the person with FASD has been resourced with the non-psychotropic medication interventions that are known to be effective for that person and for the people who have FASD. In addition to that, we strongly support and suggest that the necessary environmental and social support needed to guide the development and the functioning of the individuals are put in place. And finally, before considering any medications, that the roles of the biological rhythms of sleep, nutrition and diet and exercise have been fully attended to before the prescription of any of those medications. Once those have been satisfied and put in place, and those features of the cluster still exist, the physician then and the prescriber and the family should then move to the next step of choosing which cluster causes the most significant distress and dysfunction in the individual. And I'm going to come through that in a stepwise approach to say, once that cluster has been selected, then there is a first line of medications that should be prescribed to address the symptoms within that cluster. So if, for example, the hyperactive neurocognitive cluster is the cause of the problems the individual is not functioning, remember there will be other clusters that may be causing some problems, but which is the most significant, which is causing the most problem, which is hindering the person's progress, and which is the one that we need to address if this person will function. And so if it's hyperactive cognitive, then the first line of treatment is an amphetamine-based stimulant. And we made some recommendation based on what we found in the literature. Once this has been prescribed, the next steps for the individuals to look into is how much benefit has this medication now provided in the improvement of the symptoms that we sought to address. In some instances, there will be some improvement. In some instances, there will be no improvement. Depending on what the improvement is, the next step is to go forward with line 2 or the second line of treatment. Recall also that at the time, the individual may be facing the contribution of another cluster in the behavior. So a decision tree leads the clinician and the family to now make a decision that we made so much progress that we need to go to line 2, or we need to think about the impact of the other clusters in causing impairment in function. So this is the way the structure of the algorithm is. As you can imagine, our goal here is to ensure that step 1 is followed closely by step 2, by step 3, so that 1, function is central to what we do. Shared goals and collaboration is next in the agenda. Reduction in the number of medications is next in the agenda. And at the end of the day, there is collaboration between the prescriber, the frontline staff, the caregiver, and the patient. So that's what we sought to achieve in this process. Overall, we are now on the last stage of what we have done. So I've described the gathering of the experts, summation of the literature in form of a systematic review, the collaborative efforts to develop this algorithm, the production of the final copy, and now we are at the point of implementing and evaluating. And I'm going to be calling on the audience to join us in this last stage of the implementation and evaluation. In summary, the algorithm that we worked on to produce is a decision-making process. It emphasizes and really actually insists that the role of medication is additive, not primary. It allows for sourcing and resourcing all the environmental and psychosocial support that are essential to improve function before jumping on the role of medication. It supports very clearly that there are certain things that can be done before the choice of medication. For example, improving on sleep, nutrition, and supporting exercises. We are also aware that what this algorithm does is to reduce the number of medications that was a major concern of the Family Advisory Committee, which then allows us to choose a cluster at a time, address that cluster before jumping on the other cluster, because inherent in that process is the fact that improvement in one cluster has the significant potential of improving the symptoms of another cluster. What are those clusters? You can imagine how challenging it is to separate the multiple and varied neurocognitive variants that I described at the beginning. We chose a model that has been already utilized in multiple areas, and that is to try as best as we can to not just focus on the behavior, to not just focus on the experience, but to go even at a lower level to say, when those behaviors and experiences are put together, what is the closest explanation we can get from a molecular level? For many people, I need to warn that there is no proven state yet to say that all these clusters fall neatly into our assumed neuromolecular level dysfunction. However, it is a start. So for the hyperarousal cluster, we see that most of the abnormalities that individuals with FASD in this cluster will show will line up with deficits and dysfunction of the brainstem, the midbrain, and the limbic system. And these are usual, which many people will be aware, manifesting as hypervigilance, as agitation, as reduced pain threshold, temper tantrums, and those are not unusual for people who have abnormalities in that area. So our clusters line up and align with these particular areas, but we also recognize that none will line up as neatly as we want it to be. And that's where you come in, as we would like to review this over time to see how close we are, combining the advancement in neuroscience as well as the observation in the field when individuals are treated. The symptoms are there. I won't go through them all, but just to emphasize, for example, there are times whereby some of the symptoms crisscross in the different clusters. but it is the overwhelming evidence of a cluster of symptoms that make that cluster stand on its own. And is the recognition that they also align with a neuro basis that makes us want to address that over time. So the cognitive inflexibility, for example, is where we see a lot of problems in the orbitofrontal cortex relating to the inability to focus or to super focus on something, the inability to change strategy, which we see in a number of our patients, what we call perseveration, some of the behavioral difficulties, unawareness of risk that we see commonly, poor reasoning, and ease of frustration. So it is incumbent on us as loved ones and caregivers to be aware of what are those symptoms that are more central in causing problems for the individual with FASD, and how do we identify the most relevant cluster to be able to address that. I gave you Tony as an example. So this is an example. So before ascribing any medications to Tony, we would like to, in an interview, in an observation, to be able to be clear that these behaviors of impulsivity, aggression, irritability, head banging, and all of those things, where is it more likely to be manifest? But what is it that is causing, it's not just the symptom, but what is it that is making Tony to not function? Remember, Tony has been suspended from school, so he's not going to school. So what is it that is causing that? Well, we know that he assaulted his teacher. We know that he's been having some issues with his siblings, even though he has some good positivity. So if we, in that context, assume, and rightly so, that this hyperactivity domain or cluster is the one that is going to not make him function. We know he's irritable, which will fall into the hyperarousal, but the reason why he's not in school is because of the assault. And that could also be because of the hyperarousal or emotional dysregulation, but it's the composite picture that we leave to the caregivers and the clinicians to make that choice. Once that choice has been made, and the next thing is to be able to say, have we provided all the environmental family support and the things that we need for Tony? Is Tony engaged in a normal rhythm of sleep, diet, and exercise? And if all those are yes, then we now move on to say, what is the next step, first line medication that would address the cluster? And then if we choose the hyperactive, that means we're going to see in Tony's medication that lisdexamfetamine was probably a good choice. Now, there are processes that we will get to probably in the discussion in how do we help Tony when he already has 5 medications? How do we help Tony when we are now adding additional medication? All of those are things that most clinicians are aware of. And in the article we published, we did go into more detail on the specifics of how to make that prescription quite reasonable. So, for example, we recognize that there are certain things that have to be in place. Stability of housing, ongoing support, support for caregivers, identification of peers and friends, removing ongoing trauma and abuse, dealing with the past trauma. These are all relevant things before jumping into any kind of medication treatment. Second thing is that we really advocate that the identification of treatment goals are crucial, because it's not just treating symptoms, is that we want Tony to be back in school. We want Tony to have good relationship with his peers and his siblings. We want Tony to enjoy snowboarding. We want Tony to be able to not hurt himself. Those are all relevant goals that have to be developed and crafted collaboratively with Tony, with caregivers, with frontline staff, and the prescribers. It is helpful to recognize that there are certain things that would make treatment challenging and more difficult. For example, if Tony is under ongoing abuse, if Tony is using substances or alcohol, it is helpful to see that some of those environmental factors stabilize Tony enough. You can't not have a home and expect somebody to adhere to medications. Where do the medications stay safe? And it's important to engage everybody in Tony's cycle of support so that this will be successful in improving the functions. So we have crafted this process in a way that is easy and likely to help caregivers, frontline staff, and clinicians in managing how to help Tony, for example. So this is a sample of it, and these, by the way, are available again on the website so that people can easily be able to utilize and use it for their own clients and support that process. So this is a one-pager that takes you through all the steps, and the steps are this, whereby first confirm Tony's diagnosis, establish Tony's current baseline. What is the baseline at which Tony is functioning as is referred to the clinician? Collaboratively set some goals. What do we want Tony to be doing in the next 3 weeks, in the next 6 months, in the next 5 years? Based on the behaviors, identify out of the 4 clusters, which of the cluster or clusters, because we're not limiting it to one, we will prefer that you choose one that is causing most of the dysfunction and debilitating their function to be the ones that we're going to address. Recall that we, as a team and expert panel, recommend the use of non-psychotropic interventions first, whether it is the use of emotional regulation techniques, provision of support in terms of dietary control, supporting some of the things that have to do with school learning in maths, and supporting some of the caregivers that help to mentor the person. All of those are non-psychotropic and known to be effective to improve functioning. Once all of those are in place, then you choose the first line of treatment that targets that cluster that we said is causing the debilitation. You then observe there are processes that we included in our article. In the specific to FASD, we would like the advancement of medication to start from a lower level and to go at a slower pace. This is not specific to FASD, but is a good practice. We recommend that the person stays on those medication for at least 2 to 6 weeks, depending on how severe side effects emerge and cause dysfunction. If the functioning is not affected and the side effects can be borne, then we encourage at least a period of 6 weeks. It's also a need to ensure that the advancement in the dosage is not one that looks at achieving a certain level as advocated in neurotypical individuals. We are recommending the use of a risk-benefit ratio to determine how the dose escalation of the medication is going to be, whether you want to move faster because there are more benefits than risk, or slower because the risks are beginning to match up to the benefit. Depending on the improvement, as you can see on the right of the screen, if there is some progress and there is improvement, then dose escalation can then proceed. If, however, there is no progress or significantly minimal progress, there is a place to consider cluster 2 or move on to increase to the second line of treatment once you have reached an adequate level of medication. Side effects will always be a risk, improvement in function will be a benefit, and that needs to be calculated all the time. In our article, which the reference is there, we've also indicated that once you've reached the second line of treatment and you address the clusters and there's still dysfunction, there are certain guidelines that have been advocated for those kind of presentations that clinicians are aware of, and we refer them to those. And lastly, recognizing that there was no evidence in the literature for certain individual practices among the expert panel, we've included a couple of examples of what people have done when they reach the end of the road and what else have been adopted. And people are free to use that as far as they recognize the need to justify the use, as well as to ensure that they provide a rationale in line with the off-label prescription practice. You're listening to me. We've already begun to receive some feedback. We have a link in our website, CAN FSD, where we would really appreciate more feedback in terms of what we can do to begin to help in refining this guideline. So for example, some of the feedback that has come up is that many people would prefer specifying the starting dose. We said start low, but what does that mean? Many people are concerned about the use of medication in children. And so then what do we do about smaller children? In our estimation, we looked at the literature, and the age of 7 seems to be the minimum age for which we would allow prescription to be started. There is a need, as I mentioned earlier, to really confirm the specificity of the clusters that we have chosen. I'm happy to report that we are responding to the next request or the next feedback about developing an app that makes prescribing easier. And actually, I believe Monique, my research coordinator, is online, and she's been exceptionally helpful in securing some funding for us to move now to the next stage of developing the app. We realize that the prescribers, especially in the primary care level, are so busy that they don't have the time to do all the things that we're asking them to do. So we would like to simplify it by making it available in an app that is secure, is confidential, is private, and allows that prescribing to be easier. There's been some suggestions to include the algorithm in the electronic medical records, so that first it allows for billing purposes, which we know prompts service delivery, but also to make it possible that people would have access to this wherever they may be, in between experts and in between clinicians. So I'm happy that we are getting this feedback, but if you're listening to me, I really encourage you to support this process, and I'm going to be more specific in that request in a minute. So as I begin to wind down the presentation, I mentioned that really trying to address persons living with FASD who are manifesting one of these clusters is important. We will continue to look at the how do we address younger age group. Our goal, which interestingly we're getting into that phase now, was to evaluate the current algorithm within 2 to 5 years. So we're still within that. And now we're very happy, as I said, that we're about launching our research and developing, with the funding we have received, an algorithm mobile application. So how can you help us? As I mentioned, we have links in CAN FASD website where you can provide your prescriber with the algorithm. You can look at the symptoms to be able to help the prescriber identify, not in an argumentative way, but in the fact that you know what seems to be working, and then refer your prescriber to the website so that they can provide the data that we need to refine the algorithm. For the prescriber, this is just a sample of some of the things that are in the evaluation phase. In addition, by the way, this is just samples, so it will take about 15 minutes to complete, and it's got to be done twice to ensure that we know if there's been any benefits for the person. And we do have questions about the medications that have been prescribed, some of the side effects that the person is going through. And we also look at how it is that the person is finding the algorithm to be effective or not, and at what dose do they feel that that algorithm is working. So we do seek that process of evaluation because we believe in improving the function of the individuals, and we would like a situation whereby the individuals who are being treated these medications return to function and a refined process is in place. So in conclusion, I hope I've conveyed to you that our individuals with FASD are as varied as possible. Even though their symptoms sometimes may be confusing, we believe that we can, with adequate observation, clear collaboration, nail those into specific clusters. We recognize that having too many medications cannot in any way improve functioning. And so the role of the algorithm, in addition to simplifying processes, is actually reduce the number of complicating medications. We also have made the point that there are multiple other things that need to be in place before the pharmacological strategies come into being. We are really looking to get a collective level of experience from many people and many sources through a feedback system that would allow us to really be able to provide the adequate care for individuals who have been neglected for a long time and improve their function with the help of caregivers. I have some references as well as I think somebody was asking about the possibilities of the slides being available. We're trying to get the necessary permissions to do that. So I think I'm done. I'm going to stop sharing, and hopefully that would lead us to.
Yeah, thank you, Dr. Mela, for sharing this amazing work and really giving everyone here a better understanding of safe medication practices for community members with an FASD diagnosis. I can already see in the chat there's tons of questions already burning. So I'm going to pass it over to Eric to kind of pass those questions along to you, Dr. Mela. And I just want to reiterate that if we're unable to get to your question today, there is an email, wellness.registration@surreyplace.ca. Those will get forwarded to Dr. Mela and we'll get some answers back for you. Okay. Go ahead, Eric, if you want to share some of the questions.
Sure. Hi, Dr. Mela.
Good day.
The first question is around your is about your example using Tony, the male, the young male. The question was, is the fact that Tony is a male a factor versus being a female?
Thank you for that question. I would say yes and no. Yes, in the context that the impression that we get in terms of interpreting behaviors has for a very long time been known to be gender-based. It is unfortunate, but that's the reality of it. I have multiple examples to give, at least from the psychiatric field where I practice, but it has more to do with the response of society towards the gender and the articulation of the meaning of the behavior. So for example, self-harming. You know, if Tony was slashing up, for example, the attention to that, which we know from the literature that more females slash in general compared to males, that interpretation unfortunately sometimes carries quite a not a serious approach by the observers of the behavior. However, the head banging may escalate Tony's behavior to the point of needing more immediate attention. And of course, it's more risky to headbang. So that's where the yes comes in the interpretation of that. The no of my response speaks to how the interpretation matches the medication. We are not aware as of yet that the use of those medications will be gender-based in the context of, do we now choose a different cluster for a female manifesting that versus a male like Tony? All in all, to say that we try to base our work on the facts that at this present time, if the hyperactive cluster was chosen, we have some symptoms that justify that, whether it is in a male or a female. However, it's important that we are aware of our biases when we're dealing with a Tony versus another person who is not a Tony. So it's relevant point, but I think it's something that clinicians should be aware of. Thank you.
Thank you. Okay, we had a second question. This is regarding a specific child who is in the hyperactivity cluster. And they are taking a stimulant, a long-acting Foquest, as well as a low-dose non-stimulant, Intuitive. They are also taking sleep aids. They are long-acting melatonin and trazodone. Their second line of symptoms are mild anxiety, low pain tolerance, and sleep disturbances. The question is, would exploring an SSRI be something that they could ask their physician about? They added as well that he does wake in the night despite these medical interventions, and this contributes to a day where he struggles to stay awake, not engage in school, and also impacts his poor short-term memory issues.
By the way, I want to thank you for sharing those details. Can also appreciate, without knowing you, that you're doing a lot of work in helping your loved one because of how complex it feels already from what you are asking. I will just caution that my advice will obviously be as theoretical as you can get, based on the fact that in every vignette and every hypothetical situation, I mean, there are tons of questions you could have asked about Tony in my situation, you know, who are his friends, what else does he enjoy, and all of that. All to say is that please take my advice with a grain of salt, as well as use it in the right way to garner your relationship with your prescriber, as well as support your loved ones. So from what I can hear, I can say to you that if I were looking after the person that you've just described, there's tons of information that I would want. So I hope your clinician would want that ton of information. By the way, your clinician may already know more of the things that I'm interested in knowing. So we've identified that the hyperactive cluster, from what I'm hearing, is the significant one causing debilitation of function in the example that you gave. As such, based on the algorithm, the example already has like 3 or 4 medications. So for example, I'll use Tony as an example. In Tony's situation, if I were looking after Tony, with the permission of the caregiver, I would like to insist, number one, do you have all the psychosocial and environmental things that the algorithm mentioned in place? That's a basic assumption that I don't want anybody in this audience to bypass. We need to be sure that we have, I know resources are a challenge, I know all of those things, but it is crucial that we don't jump on medication and think we've got an answer when there are multiple things that we would have been doing before now. By the way, from all our research, there's been more advancement in the area of FASD and psychosocial interventions compared to pharmacological interventions. So just be aware of that. Let's not switch the priority. However specific, the role, if you see that from the algorithm, the SSRIs that we're talking about actually fall in two places. So first and foremost, there is a place for the SSRI to be a second line in the mood regulation cluster. So before requesting an SSRI, we want to be sure that there is a mood regulation component in the person. Number two, hyperarousal. This is one area that I think a lot of clinicians are so happy that we're able to isolate that, and the medications that we prescribe are actually so effective and relevant for a lot of individuals with FASD. Why? Because it speaks to trauma, which we know is fourfold in people with FASD than those without. So we need to address that. But the only way an SSRI gets added is after the first line has not worked or has worked minimally. And recall, the first line in that group is actually guanfacine and clonidine. So a request for an SSRI is actually like 3 ways behind where the case is. I'm not saying that it's not going to work, but based on what we have read, based on what we know about FASD, in this context, the SSRI is clearly not at the first place that we're going to be able to get. We need to very clearly identify what are the clusters that are impairing this individual, and if we believe hyperarousal as well as mood regulation is contributing, then there are first line treatment that we have to introduce, and then the SSRI will come next. So I hope, again, you know, as I said, take my advice with a pinch of salt, recognizing that you know the individual better than me. The sleep is an issue, and of course, a lot of the SSRIs disturb sleep, so I'll be a bit concerned about that. But anyway, I give you this from what we know, that the SSRI may play a significant role, but there is 1 or 2 steps before getting to that. Thank you.
Thank you, Dr. Mela. Our third question is from someone who works at the Lakeland Center in Alberta. They are currently working specifically in training and supporting teachers and school staff. Her question is, are there findings which you feel would be specifically beneficial to share with that particular audience?
Thank you very much. I believe there are. By the way, I work in Lakeland, so whoever that person is, a special hi from me, and thanks for joining. Recall that even in Tony's example, the assault on the teacher is a relevant point of entry into this question. What does the teacher know about FASD and its manifestations? What does the teacher know about the role of psychotropic medications in improving Tony's behavior, as well as reducing the incident of Tony being suspended? So some of the things that I can specifically say is that the teachers are crucial in supporting the process of identifying the clusters. They know what those clusters are. They see it. Remember that students like Tony spend a lot of time in school, 6 to 8 hours of the day, 5 days of the week. So they are closely there, whereby the teachers will know what those symptoms that we're trying to identify for each clusters are. So they can feed into that conversation. So by telling them about the clusters, telling them about the symptoms, they can help us to refine which of the clusters seem to be more prominent in this in the students that they're dealing with. Number 2, If for some reason Tony is going to be on medication, we want to be sure that the teachers also provide the psychosocial component of the students' improvement before they recognize the medication. And some of that will be, when do I say, Tony, do you want to step aside? Do you want to stand up and stretch? Do you want to keep this away? There's certain things that they can do to support the psychosocial component. Recall that there are treatments now whereby teachers help the cognitive retraining of students, help with the kind of questions that would help students to get to the answer, the necessary support that they give them in school, where they place them to sit, what the teachers need to do about the environment of the class. What are the things in the classroom that are distracting Tony? What are the behaviors of students that Tony cannot cope with? How is the lighting in the room that is a problem? How do you help Tony to manage the sound in the room? So there are multiple things that we can say to teachers that they will learn. In addition, if Tony starts to take medications and suddenly these medications are manifesting side effects, we want the teachers to know what those side effects are. Of course, we have to do it in a sensitive way, respecting Tony's confidentiality or whichever students they are under them, but they are part of the cycle of support, because if Tony suddenly is not enough in the class, we want to be very clear that it's not a side effect of medication that is causing that, or is something else that is providing the teacher with an armamentarium that will support Tony in the class. So to be general, I think all those who interact with individuals with FASD require knowledge, information, and support about FASD. In fact, in the Lakeland Center, and I believe in many of the diagnostic centers, one of our most important recommendation is to encourage the delivery of knowledge and information about best practices in FASD to teachers, to support workers, to benefit workers and social workers and all of those, because only by knowing those symptoms would you then be able to be placed in the right place to support an individual with FASD. Thank you.
Thank you, Dr. Mela. We've gotten a lot of feedback. Yep.
Sorry, I was just going to say maybe one more question just for the sake of time, if that's okay.
Absolutely. So we've gotten a lot of feedback for your answers so far. So you're getting a lot of thank yous for that. Just wanted to pass that on. And one participant said that it made a lot of sense to them, and it was very helpful. Our last question is regarding someone with a bipolar disorder diagnosis. So the question is, how would a clinician use the algorithm for a 26-year-old who has been diagnosed with FASD and more recently diagnosed with bipolar disorder with multiple psychotic breaks? Should they consider, do you want to answer that first, or do you want me to read the second part?
No, go ahead. Sorry, I thought you were done. Go ahead.
No worries, no worries. It's a two-parter. The second part is, should they consider their bipolar diagnosis and the medications prescribed for that diagnosis as more crucial than the FASD algorithm to address any FASD symptoms in the clusters?
Thank you for that excellent question. And if the audience will be given the secret of the debate of the panel, this is one of the most significant questions we had to deal with as a panel. So the answer is actually conditional. Conditional on the awareness that the clinician has rigorously adopted the two diagnoses, meaning that the FASD is confirmed and the manifestations of the mood dysregulation of FASD is not confused for the bipolar disorder. So I'm going to assume, because there's no reason why somebody cannot have FASD and bipolar disorder, the only studies that we know has those with FASD and bipolar disorder around 4%. So depression is about 20%, anxiety is about 20%, psychosis is about 1%. But in this case, I'm just going to assume that the person has FASD, has a bipolar disorder, and manifests psychotic symptoms. Now, recall that, again, my answers will be as hypothetical as possible, but I think those are not unusual vignettes or scenarios that we deal with. I want to be very clear that the person is not using substances, because one of the things this afternoon that we'll be talking about is the use of cannabis. And indeed, the rate of the use of cannabis in individuals with FASD is significantly high. As well, the impact of the cannabis in causing a disturbance in function, especially of a psychotic one, is also very relevant. However, in implementing the algorithm in this context, what we chose to do specifically is to suggest that part of the psychosocial support that we are advocating and insisting on will help tease out those who are bona fide bipolar with psychosis from those who are FASD with mood dysregulation. Not all the time, but to some extent, because as you can imagine, if the person has a bipolar disorder, there is not a lot that social environmental support is going to reduce the manifestations of mania and the psychosis that occur, maybe to some extent, but very minimal. But if you have FASD, you will see a noticeable reduction in some of the manifestations. So if that was the case, and the person turned out to have more FASD than the bipolar with psychosis, then we suggest that the person should go through the algorithm. Recall that after the second line of treatment, there is a recommendation of a third line and an adjunct. The third line is what the questionnaire is saying. It is when you have tried this and found out that the bipolar symptoms are still unabated, the psychosis is still there, or the risks of continuing on the algorithm overshadows the benefit, then we fast forward to go to the existing algorithms for bipolar treatment. So we recognize that there are already algorithms for things like post-traumatic stress disorder, major depression, anxiety disorders, bipolar disorders, schizophrenia, and so the weighing of the risk benefit allows you as a clinician to say, you know what, it's taking me 6 weeks to get this medication into this individual to prove that it's FASD and the benefit, but I can see this person not sleeping, grandiose, overspending, dysfunctional. I'm not going to wait. I'm going to switch to that based on the fact that the two diagnoses exist and there's no confusion that this is just a mood dysregulation from the FASD. If the clinician allows the system of going through the decision tree to go and the improvement exists, it serves two purposes. It confirms to you that probably the diagnosis of bipolar disorder may actually be safely embedded in the manifestations of the FASD and allows you to reduce the consequences of the drugs. Before I finish, just note that in the in the mood dysregulation component of FASD, because we know that there's been a confusion between the manifestations and that a mood stabilizer is actually the first line of treatment. Now, I know it's complicated by the fact that the questioner asks the presence of psychosis, which then makes it unlikely that you're going to get, for example, an antipsychotic for that individual because you're insisting on using a mood stabilizer, which we say is divalproex and lamotrigine for obvious reasons, it is possible that the improvement in the bipolar symptoms may have come as a result of the use of a mood stabilizer. What does that all tell us? Tells us that there are still a group of individuals that by following this algorithm strictly, we may not be able to know whether their manifestations are actually a bona fide bipolar disorder or subsumed within the manifestations of the prenatal alcohol exposure. But a very valid question, one we struggled with, one we came to, and the way I've just described it, but recognize that we would appreciate any feedback from clinicians and family on how that has worked out, if indeed going with the algorithm resolves the issue or going with the bipolar guidelines is a better option. Thank you.
Thank you for those wonderful answers, Dr. Mela. So that's going to wrap up the first presentation for today. I want everyone to take a 30-minute wellness break. So feel free to stretch your legs, grab a coffee, grab a tea. We're going to meet back at 1 p.m. And that is going to be for Dr. Mela's presentation on the benefits and impacts of cannabis in adults with FASD. So I invite everyone to stay on the link. So if you are here, maybe just mute your camera, mute your mic, and just walk away. We are going to start on the same link in a half an hour. So I just have a few little wrap-up pieces. If anyone wants information on other Surrey Place events, you can check out our website and stay connected to us through social media. And for those of you who are not able to stay for the second half, we want to let you know that your feedback is really important to us, and we want to hear about your experience from today. So very soon you'll receive just a little survey in your email, and you can use, it'll go to whatever you registered for today's event. And we just would really appreciate if you took the extra few minutes to just fill out that questionnaire for us. So thanks everybody for joining this first session. And for those of you who are joining the next presentation, we'll see you guys again at 1 p.m. Thank you.